Thank you to the moderators and SAGES for the opportunity to talk about something new and relevant to all of our careers. The purpose of this talk is to give insight on how to obtain privileges for a new technology or procedure a surgeon would want to add to his or her practice. I have no disclosures. So with the advent of new technologies and procedures, kind of over time, a learning curve exists, and this has been evident with technologies like electrocautery and energy devices, development of endovascular procedures, laparoscopy in the 80s and 90s, and now robotics. And so in my personal practice, I'm currently relearning robotic surgery and better techniques for ventral hernia repairs to add to my practice. And as a surgeon, learning new techniques and procedures is important to continue to optimize care for our patients. How to do this is something I ask myself almost every single day. So the goal of this talk is to define credentialing and privileging and what it means, identify the problems in credentialing and privileging, describe published attempts to improve the process, and end with maybe an approach to gain competence in new technology or procedures if there's not an approach at your hospital. So when researching this talk, I started with a call to my credentialing department at my hospital, and two scary words came out, the Joint Commission, which were uttered several times. So after I calmed down, it led me to kind of a deep dive into their website. And so I learned a little bit about what they view as credentialing and privileging, which is credentialing is a process of obtaining, verifying, assessing the qualifications of a practitioner to provide services and care. And this requires an examination of the practitioner's licensure, education, training, experience, and other qualifications. Most commonly, we rely on volume or letters from mentors and colleagues to demonstrate our experience. However, there's no way to validate quality of training, as the person or entity doing the credentialing may not have ever witnessed what we actually do. So what if you want to do something new? This is not mentioned at all in the Joint Commission website. Privileging is the process whereby the specific scope and content of the patient care services are authorized for a practitioner by a healthcare organization. This is what gives us, as surgeons, the right to use our skills to perform a specific set of procedures within our institution. Continuous privileging takes into account both currency or volume of cases and competency or ability to perform a surgery. But again, what if you want to do something new? So this then question led me to find out what surgeons think of credentialing and privileging. And Justin Dimmick's group at University of Michigan has asked the same question. In a paper published in 2017, 116 surgeons were surveyed about their perceptions on credentialing and privileging and the requirements to use a new technology and or do a new procedure. 69% of respondents stated that the process was either too relaxed or somewhat too relaxed. When asked about training needed to become credentialed and privileged, surgeons had varied answers on the requirements for minimum training to use a new technology or perform a new procedure. The variation depended on surgeons' experience. So for a surgeon with no experience, the majority of respondents believed a mini-fellowship should be pursued, whereas a surgeon with some experience should either scrub in cases performed by an expert or be mentored or proctored through a new technology or procedure. The heterogeneity in these answers given by the surgeons reflect the heterogeneity that exists in the credentialing guidelines across the United States. In actuality, there are no accepted guidelines or standards for credentialing, privileging, and or training. They differ from hospital to hospital, and the interpretation of case quantity and quality differs as well. Furthermore, if credentialing is too lax, then this can lead to a negligent credentialing, where a surgeon is credentialed for a new technology or procedure without adequate training. Negligent credentialing is now a valid malpractice claim in over 25 states, which means hospitals also bear joint responsibility for our medical malpractice related to poor or lax credentialing. So the heterogeneity in this process leads to several gaps. First, to get credentialed for a technology, many times surgeons will get proctored on a more straightforward procedure. Is having me proctored on a robotic gallbladder or a hernia the most effective way to foster a culture of safety if I'm eventually going to apply robotics to duodenal switches? A question I ask every day. Second, getting credentialed to use a new technology or do a new procedure does not mean you're good at doing it. A true gap exists due to the learning curve in trying to become competent. So how do you go about tackling that learning curve? Well, since the focus of the fourth talk is on how to manage the learning curve, I'll just briefly touch on surgeons' perception of how to learn a new technology or procedure. So that same group from University of Michigan surveyed 122 practicing surgeons on how they learned new skills and procedures. And interestingly, there were significant discrepancies between what the most effective training method used and what was perceived to be the most effective. So for example, 16% of surgeons believed a mini fellowship is the most effective way to learn a new skill, but only 2% of surgeons actually do this, partly because the time and cost of doing a mini fellowship. While the most common method used by surgeons to learn a new skill was self-directed learning, only 7% felt this to be the most effective method. And then similarly, only 15% of surgeons utilized a proctor to help learn a new skill when over 31% believed it to be the most effective. While this study demonstrates that as surgeons we have different opinions on how to learn a new technology, or a new procedure, there's a paucity of data on the outcomes of adopting a new skill utilizing different training methods. So with the lack of data and the most effective method to become competent and that heterogeneity that exists in credentialing and privileging, it is hard to come up with one method to approach learning and credentialing a new skill. Nevertheless, SAGES has taken this on more than other societies. If you look on their SAGES guidelines website, there are 7 papers focused specifically on credentialing new techniques and procedures. For example, in 1998, SAGES published guidelines on credentialing for laparoscopy and thoracoscopic surgery. In 2008, they published kind of a consensus statement around robotic surgery training and credentialing. And in 2014, they published a paper on how to introduce new technologies and techniques. So focusing in on these 3 guidelines, the guidelines in privileging for laparoscopy and thoracoscopic surgery includes guidelines for already practicing surgeons, not just trainees. So besides completing a general surgery residency, which if you're a practicing surgeon, you've done, the guidelines recommend training directly from a surgeon with expertise in desired technology or the procedure of interest. They also recommend completing a didactic course. And once completing these steps, the guidelines then recommend ongoing proctoring until proficiency is met. SAGES and MIRA then published guidelines as a consensus group with the goal that surgeons using the robot have the judgment and training for safe completion of a robotic procedure with the capability of troubleshooting complications related to the robot. The requirements outlined in the guidelines include completion of a residency, a structured training curriculum, if not learned in residency or fellowship, that includes didactics, hands-on training, and observation of experts in the field. In granting privileges, it is also important to have practical experience that includes satisfactory outcomes in an equivalent procedure, initiation of clinical experience under the guidance of a mentor, and proctoring under competency or until competency is obtained, which should include a formal assessment of some kind. And once competency is achieved, then provisional privileges can be given with ongoing monitoring. Lastly, the guidelines were also written on how to introduce new technology and techniques, and they also have how to do this in an ethical manner as well. With the introduction of new technology and techniques, it should be monitored by an it's kind of similar to the other guidelines, I'm sorry. Education is key. So first, surgeons need to have relevant training and privileges in the affected organ system so they can address anticipated complications. And secondly, surgeons considering the use of a new technology or technique should have training to decrease the learning curve related complications and improve overall patient safety. The responsibility of training in these new technologies and techniques should fall to experienced centers and specialty societies like SAGES with industry as support. Furthermore, the introduction of new technology and techniques should be monitored by institutional credentialing and privileging bodies, new technology committees, and the IRB. And then lastly, the effectiveness of this new technology or technique should be monitored and continually examined and assessed to ensure that it's optimal for patient care and outcomes. So in summary, training into competency, credentialing, and privileging are intimately related issues with significant heterogeneity described in the literature and actively being practiced today. With the boom in new technologies and procedures, written guidelines now exist and will continue to be written to aid safe and effective implementation of new technologies and procedures. However, if you don't have a plan or you don't have a guide at your hospital to help you out for new technologies and procedures, this is how I would approach it. And this is what we've used at Washington University for implementation of robotic surgery. So first, get it out there. Start by applying for privileges at your institution. It'll allow you to create a partnership with the hospital and develop a culture of safety with innovation. For physicians in practice already, ensure that you already have privileges to perform similar procedures on the organ system that you would like to apply the new technology or procedure to. Complete both didactic and simulator training. Hopefully this will include observing an expert in the skill, technology, or procedure of interest. And lastly, unless you are the first to utilize a technology or perform a procedure ever, it's a good idea to be proctored. So most surgeons innovate every day. It's important to foster a culture of safety when utilizing new technologies and surgical procedures. Thank you very much for your time, and I'd be happy to entertain questions.
Thank you.